Hello everyone. Very warm welcome. I hope the voice is clear and screen is clearly visible. Good evening, ma'am. Good evening. Good evening. No sound. I think sound is there. Yes. Okay. Thank you.
Yes.
Yeah. Thank you. Thank you so much. Thank you so much. First of all, I would like to congratulate each one of you for such a hard work and bringing so much proud and laurels to me too. And I really trust you and love you all. And thank you so much for your support and ever being so cooperative. And one of the best students for me. Right. So there are certain new students also here for this live session. So I welcome you all to MRCOG courses. And thank you so much, Dr. Devika. Thank you. Thank you, everyone. I'm really thankful to you all. Thank you. Thank you, Dr. Harshada. So today, this session is all about the new guideline, nausea and vomiting, and in pregnancy and hyperemesis gravidarum. Hello, hi everyone. Yeah, I am receiving too many chat messages, so I'm saying hi to everyone, right? So basically, in this guideline, this is a very important guideline. Although always we think of like that nausea and vomiting is a very common thing we have been seeing in our practices. So why RCOG is so much worried about the nausea vomiting? In all your papers, you will get some questions of nausea and vomiting. Certainly, it is fixed. Question has to come from this guideline, right? And since this time, this is a new update, so largely part 3 people can even get a case on it, right? So now this guideline is more expensive. So you can have, it's more expanded and you can have more clarity in the management of these patients. Kindly mute. Okay. So I have muted everyone. If you want to ask any question, you can unmute yourself. Otherwise, please stay muted, right? So basically, I was telling you that why this guideline is important, because the hospital stay, as you all know, it is completely managed by the NHS. So as the hospital stay increases, it becomes expensive for the NHS and a huge amount of burden goes there. So therefore, the logic is that they want to manage mostly in the community care, and if needed, then ambulatory care, right? Inpatient hospital should be reduced to minimum. So therefore, keeping in mind that concept, this guideline has been updated. So now the concept of management at home, management in community care is more. Like there are more options for the community care rather than shifting the patient to the inpatient care, right? As we go through the guideline, I will be pointing on what are the points which are different from the previous guideline, right? So all those who have read the previous guideline also, they would come to know where actually the differences are and how it will affect their question, answering of the questions, right? So let's start. Okay, so anytime if you find any difficulty or if you have any queries, you can just unmute and let me know or write in the chat box, whatever way you are comfortable. So let's start with the incidences first, right? So incidences are always more important. And secondly, definitions. When to classify patient as NVP, when to classify patient as hyperemesis. This is the first thing. Whenever you have a question in your exam, first see whether it is a question of simple nausea vomiting or they are talking of hyperemesis, because that will make a difference totally in the further investigations and management. So incidences, the nausea and vomiting is defined as symptom of nausea or vomiting during pregnancy when onset is prior to 16 weeks of gestation. So first cutoff point here is it should be prior to 16 weeks of gestation, and there are no other causes which are like responsible for the nausea and vomiting. Important ones like gastroenteritis, patient of UTI. So these are the common things, traveler's diarrhea. So these common things, these are associated with nausea and vomiting, right? So those all should be ruled out. This is a diagnosis of exclusion, right? When you exclude the common conditions and you don't find any cause, but there is nausea and vomiting, then we call it as nausea and vomiting of pregnancy. And it is very important to note the 16 weeks cutoff. Now, this affects up to 90% of the pregnant women. So this is a very, very common thing. And it is the most common indication for hospital admission among pregnant women with typical stays of between 3 and 4 days. Now, you know why NHS is so much worried about it. 3 to 4 day admissions for the patients, it costs them around a huge amount. So NVP typically starts between 4th and 7th weeks of gestation, peaks in approximately the 9th week, and it resolves by 20 weeks in 90% of women. Each of these points is a point for exam question, right? So when it starts between 4 to 7 weeks, when does it peaks? It peaks at 9th week. And when it resolves by 20th week in 90% of the women, right? So there are multiple exam points here. One is this cutoff of 16 weeks. Then the another point is starting between 4th and 7th week. Then another exam point is peaking at 9th week and resolves by 20th week. Now, hyperemesis, this is a severe form of NVP and it affects 0.3 to 3%, 3.6% of pregnant women. To remember it, you can remember it 0.3 to 3.3, right? To make it easy, something around only 3. So 0.3 to 3.3 is an easy way to remember this. It's only 3 because you have to remember these incidences. They are important ones. So 0.3 to 3.6% of pregnant women, interfering with the quality of life and ability to eat and drink normally, right? Now, hyperemesis, when will we say? So previously there was a different type of definition in which they were mentioning about the 5% weight loss and all those things. But now they say that it is diagnosed when symptoms starts in early pregnancy and they are severe enough to cause an inability to eat and drink normally, and it strongly limits daily activities of living, right? So now from the objective measurement of weight loss, they have shifted the definition to the clinical part. Now this is the quality of life which is being affected. The assessment of the quality of life, the severity with which the quality of life is being affected defines the hyperemesis rather than objective measurement of weight loss, right? So this is one very important change here. So this is there. It should be severe enough to cause inability to eat and drink normally, and it strongly limits the daily activities of living. Signs of dehydration are contributory to the diagnosis. Previously, we used to take the ketonuria as an indicator of dehydration, and we used to consider that if there is ketonuria, we have to take patient for the inpatient management or needs the IV fluids, but it is not so. Ketonuria in pregnancy is not an indicator of dehydration in pregnancy and should not be used to assess severity. This is a major change, and this definition, this line is going to change your answers in the recall questions as well, because they give you the recall questions where they talk about the ketonuria and then they ask where patient will be managed, community care, ambulatory, or the inpatient. So previously we used to take it as inpatient for the ketonuria, but now it is going to change, right? So ketonuria is not an indicator of dehydration in pregnancy and should not be used to assess severity. This definition represents a shift from the historic reliance on objective measures. Okay, so you are shifting from the objective measures such as weight loss and electrolyte imbalance towards the subjective patient-focused criteria, right? So this is a major change in this new guideline. Now, hyperemesis is not defined by the objective measures. Rather, it is the patient's subjective criteria which determines the severity. Right? Is this point clear? Any confusions about it? Right. So what are the biochemical abnormalities which are associated here, right? So biochemical abnormalities, sometimes you find questions in exams regarding this also. So accordingly, you will have to answer. So hyponatremia, hypokalemia. Hypokalemia can sometimes be hyperkalemia as well, but hyponatremia is always there. Low serum urea is there. Raised hematocrit. You may find biochemical thyrotoxicosis in which there is raised thyroxine levels. TSH may be normal or slightly reduced because this is thyrotoxicosis. So TSH may be either normal or it may be slightly reduced. This is because of the common subunit between the TSH and the HCG, right? So both of them, they share a common subunit. So because the HCG is increased in these patients, so you may find this also. Now, liver function tests are abnormal in up to 40% of the women. Again, an important figure to be remembered for exam. And largely, you will find alteration in transaminases. Bilirubin generally remains the normal, same, right? Largely, it is the transaminases which are affected. So all these disturbances, they are important exam questions. One question about this thyroid thing is that they give you a scenario of first week, first trimester of pregnancy, right? Same in this situation where the nausea and vomiting can be there. And they give you certain thyroid levels and then ask you for the treatment. So remember, this thyrotoxicosis, which is associated with NVP, is not treated, right? We do not use any medications to treat this thyrotoxicosis, right? So you have to wait till the first trimester goes off, this NVP settles down. If after that also it is persisting, then you may have to go further tests like thyroid peroxidase antibodies, or these things have to be done and managed accordingly. But if it is first time you are finding raised T3 levels in these patients of NVP in this period, then you don't have to treat that. And this is important point for exam question. There are recalls focused on this particular question. Now coming to some of the important points in the history, right? This sequence would be important for the part 3 students as well, because you will have to ask all these things in your history. If you have a scenario of nausea and vomiting, you will have to ask all these. So previous history, because there is a recurrence. If there one pregnancy, there is NVP or hyperemesis, in next pregnancy, recurrence can be up to 15 to 81%, right? And if it is hyperemesis, then in next pregnancy, it can be as high as 89%. In further slides, I'll again come back to these percentages. Quantifying severity with the PUQE or the HELP score. Nausea, vomiting, tylism, that is hypersalivation, splitting, weight loss, inability to tolerate foods and fluids, effect on quality of life, and ability to perform daily activities. Now you know how important is this question, because this is going to define your severity, whether the patient is NVP or hyperemesis. This is the point which is going to define. Ask about self-reported nutritional status or rapid weight loss. Another comorbidities like epilepsy, this diabetes, HIV, or all any of the condition for which the patient is taking regular medication. This is important because when the patient is not able to tolerate anything, she won't be even able to tolerate the drugs. And she is not tolerating the drugs, or she is not compliant with the drugs, the diseases are bound to worsen. So we are bothered about the other associated conditions as well. Relevant surgical history like gastric bypass, band, or sleeve. So there will also be a problem with these types of conditions. Now you need to exclude other causes. As I said, this is a diagnosis of exclusion. So we have to rule out other common conditions. So any condition in which there is abdominal pain, like it could be gallbladder conditions or it could be pancreas. So you have to rule out abdominal conditions or simple GI conditions. Then even GERD, esophageal reflux. So those all need to be ruled out. Urinary symptoms, UTI, any type of infection that can also lead to nausea and vomiting, any drug history, or chronic Helicobacter pylori infection, chronic cases of gastric ulcers. So these all things you need to rule out before you go and tag a patient as a nausea and vomiting of pregnancy. What all things we need to look for in the examination? Of course, the general management, that is temperature, heart rate, because tachycardia and dehydration, blood pressure, again, loss of, if patient is more dehydrated, there could be hypotension, oxygen saturations, respiratory rate, abdominal examination, weight, signs of dehydration, like sunken eyes, dry lips and mouth, oliguria or anuria, tachycardia and hypotension. Then signs of malnutrition or rapid weight loss. So now this is one of the examining features, right? So greater than or equal to 5% pre-pregnancy weight and muscle wasting, which can be measured by mid-arm circumference. Neurological signs as such are not part of NVP. There are two circumstances where you can find neurological signs. One is if the patient is hyponatremic, she may have CNS signs because of hyponatremia, or she is going into the vernix encephalopathy where she can present as confusion, nystagmus, or ataxia, which can indicate vernix encephalopathy. Similarly, same kind of confusion can also occur in hyponatremia. There is one feature which can differentiate between one neurological feature which differentiates between the hyponatremia and the vernix. Any idea? Anybody would like to answer that? Oh, yes, I think there is answer. Very good. It is seizures or convulsions. Yes, very good. So hyponatremia, you have seizures and convulsions, but in vernix encephalopathy, there is never seizures and convulsions. So this is one feature which differentiates between the two. And again, an important point, right? When your exam scenario mentions about the seizures, then question is not about vernix encephalopathy. It is about hyponatremia, right? This is how we have to fix keywords, right? So fixing your word as if this is a thing, then it is going to be hyponatremia and we have to manage that rather than vernix encephalopathy. Now coming to investigations. What are the investigations we need to do? So we just said that we have to rule out UTI. So for the urine, we'll do nitrites that may indicate infection. Ketonuria in pregnancy is not an indicator for dehydration. So now ketones in urine does not actually affect your management. Midstream urine is important if your dipstick test shows the UTI. Urea and electrolytes to guide the intravenous fluid and electrolyte replacement, right? So they are important because you will decide the electrolytes, what all you have to provide. Full blood count is important to rule out infection, anemia, and raised hemoglobin and hematocrit, which is associated with the dehydration and NVP. Blood glucose levels to diagnose diabetes, and you want to exclude diabetic ketoacidosis in patients with diabetes because these patients will also be having nausea and vomiting. Ultrasound scan is important. Assess if viable intrauterine pregnancy, multiple pregnancy, or trophoblastic diseases, right? This is very important because as the HCG is more in like multiple pregnancy or trophoblastic disease, so is the chance of NVP as well. Thyroid function test in refractory cases or where the patient needs repeated admissions. Okay, she is not getting benefit by the routine medications and she is again coming back for the inpatient management. LFTs again in refractory cases and exclude other liver diseases such as hepatitis, gallstones, and monitor malnutrition. Amylase exclude pancreatitis, right? So some of the tests are being done to exclude other causes, and some of the tests are done to see the condition, present condition of the patient, so that you can give her proper management. Now, these are the scoring systems which are important. So PUQE and HELP scores are very important. And the other one, that is for the malnutrition universal screening tool. This is for the weight loss, right? For weight loss, you can do two things. One is you can use this tool, and the other one is you can use the mid-arm circumference measurement, right? So these things can be used. The most commonly, your management is going to be based upon the PUQE score, which is mentioned in your exam questions. And then you have to choose management according to that. So now this is a score, 24 score, right? So in this, actually PUQE 24 is the name, but 24 is not the total score. Total score is 15, right? So why it is known as PUQE 24? Because you assess whatever questions you use, you are asking for those symptoms over a period of last 24 hours, right? So therefore, the name is given as PUQE 24. So now these are the questions in front of you, as you see. So basically, you have to remember this, right? When we call it as mild, when we call it as moderate, and when we call it as severe, right? So mild is 6, moderate is 7 to 12, and severe is 13 to 15. So when I go on to the further slides of management, I will talk of like your PUQE score is this, so you will manage according to this score, right? So just remember these three here: mild 6, moderate 7 to 12, and severe 13 to 15. This is another more complicated, oh my God, scary tool, which is hyperemesis level prediction score. But again, you need to remember the basic score. That is none or mild, less than or equal to 19. Moderate is 20 to 32, and severe is 33 to 60, right? Seems scary, but we don't need to remember each and every point out of it. Now, coming to management. Any questions till now? Is it fine? Shall we continue? We start with the management, right? So
Yes,
basically, there are 3 levels of management. Thank you so much. So there are 3 levels of management: community care, ambulatory care, and the inpatient care, right? So there are 3 levels. Community care is either the patient stays at home, and the community people in midwife or whoever is caring in the community will take care of her. Ambulatory day care is where in a day, it's like a day care unit where a patient comes, takes the treatment, and by the evening she gets better and she goes home. Third is inpatient care, in which the patient is admitted and she stays there, right? So now we have to see what are the indications when we how to decide what level of care we are doing and what all is provided in that particular level of care. So community care is women with mild NVP should be cared for in community with antiemetics. So you can either use the oral antiemetics or you can use intramuscular antiemetics, right? So no IV, right? So oral or intramuscular. Management in the community or primary care is appropriate to avoid unnecessary hospital admissions and disruption to the woman's life, right? So she can be treated with the oral or intramuscular antiemetics, and it is usually the mild type of nausea vomiting. Now, although it does not mention the IV, but they have now recently introduced a concept, a word in the guideline in which in-house hospital, right? So sometimes, like if patient needs something for the dehydration, like she is getting benefit by the oral or IM, but she needs some fluid, for a short while, right? She is dehydrated. So if the facility is available, then the fluid can be even provided at the home. Just a single drip or something, if required, that can be given at home. As I initially told you in the beginning, they are actually trying to bring the healthcare to community from the inpatient. So now they have said that if the patient is on oral and intramuscular antiemetics, and if she needs any rehydration, that can be given, short duration rehydration can be given at home too. So in-house hospitals can be created if adequate facilities are available. So this is totally a new concept which was never there in the previous guideline. Now coming to ambulatory daycare, where your community or the primary care measures have failed. So if women are unable to tolerate oral antiemetics or oral fluids, if she needs some amount of IV antiemetics or she needs the IV fluids for some period of time, then it is ambulatory daycare management is appropriate. We will just now talk of PUQE scores, and accordingly we will decide what type of management is good for what patient. Inpatient is considered if there is at least one of the following. Remember, this is one of the following, not all. If any one of this is there, then we will choose inpatient care. So continued nausea and vomiting and inability to keep down oral antiemetics. Now, this is mark this as a keyword for your exam question. If they are using inability to keep down oral fluids continuously, right? It should be continued, continuously. She is not able to keep down oral antiemetics, then inpatient care is recommended. Continued nausea and vomiting associated with clinical dehydration or weight loss greater than 5% of body weight despite oral antiemetics. So now greater than 5% of body weight. Confirmed or suspected comorbidity. If like patient is on UTI, she is unable to tolerate the oral antibiotics. So anyhow, she requires parenteral management. Comorbidities where symptoms or inability to tolerate oral intake and medication could present further complications, right? Patient is not able to be compliant with her medications, so she needs parenteral management. So complications, any complications which are associated because of, directly because of the vomiting, like weight loss, or maybe because of the associated conditions. In those cases, we need inpatient management. Now, what are the recommended antiemetic therapies and dosages? So only medication which is licensed to be used in UK as an antiemetic in pregnancy is doxylamine and pyridoxine combination. 20 milligram per oral at night, per oral by mouth at night. And it can be increased to additional 10 milligram in the morning and 10 milligram at lunchtime if required. So this is the only combination which is licensed to be used in UK. Rest are all first line drugs and they can be used. So cyclizine 50 milligram per oral IM or IV 8 hourly depending on at which level you are managing the patient. Prochlorperazine 5 to 10 milligram 6 to 8 hourly per oral or 3 milligram buccal, 12.5 milligram 8 hourly IM IV or 25 milligram per rectal. It is very important to remember these drugs, their names and their dosages also, because they sometimes in EMQs they give you slight differences and the dosages. So if you have not learned the dosages properly, then you may get confused in choosing the EMQ options. Promethazine, this is 12.5 to 25 milligram 4 to 8 hourly per oral IM or IV, and chlorpromazine, right? So these are 4 drugs in the first line. Second line, now this is very important. Metoclopramide, because of its extrapyramidal side effects, it is always kept as a second line. Now they are using this subcutaneous metoclopramide in the community care as well. So along with the oral and IM, subcutaneous metoclopramide is a addition in the community care management as well, right? So this is also a new thing here. Domperidone 10 milligram 8 hourly per oral or 30 milligram 12 hourly per rectal can be used. Ondansetron. Ondansetron is a very, very safe drug, and now they are using it more often as compared to previous guidelines. So they are recommending it more often now, and they say that it is safe. There is a very slight chance of orofacial clefts which can occur. In next slides of adverse effects, safety profile, we'll be talking of that. But now they are considering it more safe as compared to the evidence in previous guideline. So 4 milligram 8 hourly or 8 milligram 12 hourly per oral, 8 milligram over 15 minutes, 12 hourly IV 16 milligram daily PR. So women taking ondansetron may require laxatives if constipation develops. Finally, when your question says that she is not responding to any of the antiemetics, she has got resistant. When they use the word resistant, then they are asking for the answer as corticosteroids, right? Not getting benefited by any of the medications, that is a resistant nausea and vomiting. So finally, and she has tried combination of antiemetics as well. So finally, when they ask which is the last option, then it is going to be corticosteroids, right? Like this questions come in exam. First line, drugs you have to choose from this particular column. Not getting benefit, you have to add 2 drugs, right? Rather than replacing the first drug, you have to add 2 drugs. But definitely the second drug which you are adding should have a different mechanism of action. So mostly you will be adding from the second line drug, right? Now the 2 drugs not working, resistant patient, move on to corticosteroids. So your EMQ will be answered like that, right? So first line, not getting relieved, add second drug of the different mechanism of action. So largely from the second line, and not working, move on to resistant, that is corticosteroids. Like this, your question is going to evolve. So for hydrocortisone, 100 milligram twice daily IV, and once clinical improvement occurs, you can convert it into the prednisolone 40 to 50 milligram daily per oral, with the dose gradually tapered until the lowest maintenance dose that controls the symptoms is reached. Now, corticosteroids should be reserved for cases where standard therapies have failed. So this is very important key point here. When initiated, they should be prescribed in addition to previously started effective antiemetics. And women taking corticosteroids should have their blood pressure monitored and a screen for diabetes mellitus, because there are chances of development of GDM with these drugs. So the monitoring is very important. Now, this is the chart. So basically, you see, this is the algorithm how you have to manage. So once you have done the initial management and you have defined the PUQE score. Now, if the score is between 3 to 12, you can manage patient in community. If it is more than 13, then she requires the ambulatory management. Now, with any PUQE score, but complications occur, then you require inpatient management. Sorry. So this is how you are going to define from initially whether your patient is for community, whether your patient is for ambulatory, or whether your patient is for inpatient management. So management in community, antiemetics, you can start as per we have just talked in the previous slide. Support and reassure, encourage oral hydration, and offer her dietary advice. What is the dietary advice? She should be eating little and more often so that she is not empty stomach. Consider the use of laxatives if required. You can prescribe. Yes. Oh, okay. Let me mute. Okay. So prescribe the histamine type 2 receptor blockers or proton pump inhibitors if women develop esophageal reflux disorder. Mental health assessment, very, very important. See, RCOG is mad about the mental health this assessment. So this is very, very important because these patients, the quality of life is getting affected. So mental health is very, very important. You may not get a question about that in your part 2 exam, may or may not, but for part 3, this is must, right? So mental health assessment is must to be talked for part 3 candidates. So these all things you have to do for patients in the community care. Reassess the patient after 24 to 72 hours. If she is improving, continue with this. If minimal or no improvement is there, then as I told you, we can add second antiemetic or next antiemetic. When up titrating, add drugs as compared to replacing them. So don't replace the first line by second line. Add second line to the first line, right? And in second line, you have drugs with different mechanisms of actions. So you can add different drugs, right? So don't just remove the first line, add second line, right? This is important because there are recall questions where they ask, patient is not getting benefit, what to do? Then refer to inpatient management if there are red flags. So PUQ is score greater than or equal to 13 with no complications, inability to tolerate oral intake, and community measures failed, refer to ambulatory day care. If any PUQ score, any of the score, okay, it is not only above 13 only, but there are complications. She is persistently or continuously inability to take oral intake. She is not responding to outpatient management, which obviously means that the symptoms are continuing in spite of the treatment. Clinical dehydration is there. Weight loss is greater than 5% body weight, or confirmed or suspected comorbidity is there. Confirmed or unable to take medications which are affecting her epilepsy, HIV, or psychiatric disorder management. And there are concerns about the mental health. So any complications with any PUQE score, you will do the inpatient management. So very important slide for your EMQs and for your exam questions. First question is where to manage this patient. Now coming to the ambulatory care management, what to do here? So here in the ambulatory care, if your patient is there, insert Venflon and send relevant blood test. Prescribe antiemetics with IM or IV. Prescribe IV fluids, 0.9% saline with 20 millimoles KCl over 1 to 2 hours. So this is important. And thiamine supplementation, either thiamine 50 milligram TDS per oral or Parbinex, which is IV. So that is to be given. So IV fluids, the recommended one, saline with potassium and thiamine supplementation, that has to be done. So this is for the ambulatory care management. What is inpatient? So inpatient, we have already talked about the indications. Any score with unresponsive to outpatient management, clinical dehydration, inability to tolerate oral intake, weight loss is more, suspected comorbidities, or not able to take medications. Then you will go with the same things. We are giving IM or IV antiemetics. We are giving IV fluids, but here we have to monitor the electrolytes daily, right? Thiamine is to be prescribed simultaneously. This one, which I have marked, is very, very important. When patient is an inpatient, you have to do venous thromboprophylaxis assessment, right? And you give her low molecular weight heparin for the duration of period when she is admitted in the hospital. This is a transient risk factor. Hyperemesis gravidarum or inpatient management is a transient risk factor. So you have to start low molecular weight heparin for a duration of the period when the patient needs hospital stay, right? So once the patient goes home, then you can stop low molecular weight heparin if other indications are not there. Rest all, prescribe histamine type 2 receptor blockers, undertake the mental health assessment, and if required, you can refer to mental health services. If the patient is being managed inpatient, then you have to schedule the ultrasound scan to confirm the viability, gestational age, and to assess the trophoblastic disease or multiple pregnancy. Because these can be associated with, sorry, these can be associated with high chances of hyperemesis. So if there is a trophoblastic, certainly you will be required to manage that first simultaneously with this. So ultrasound is important if the patient is in the inpatient. Inquire regarding constipation and prescribe laxatives. If required, you can consider enteral or the parenteral nutrition where all the other therapies have failed. Fine. Any questions till now? Okay. Is it clear when to refer patient to community, when to manage in ambulatory, when in inpatient, and what all we are going to do there in these patients, right? Thank you. So that's good. Okay, I think yes. Okay, thank you very much. So safety of drugs. Now, women can be reassured regarding a very small increase in absolute risk of orofacial clefting with the ondansetron use in primary trimester, which should be balanced with the risks of poorly managed hyperemesis. In women requiring intravenous fluids, we already talked of, it is important to recognize hyponatremia and hypokalemia. So very, very important to do the monitoring of daily electrolytes if patient is continuously on IV fluids, which is there in inpatient management. Esophagogastroduodenoscopy, that is safe if patient is having hematemesis or there is severe epigastric pain, then you may like to do this. Wernicke's encephalopathy due to vitamin B1 thiamine deficiency classically presents with blurred vision, unsteadiness, confusion, memory problems, drowsiness. And on examination, there is usually nystagmus, ophthalmoplegia, hyporeflexia or areflexia, gait or finger nose ataxia. So hyperemesis, in the hyperemesis, this is actually totally preventable, although it is a fatal medical emergency, but it is totally preventable. If you are taking care of not giving the dextrose solution or adding thiamine properly, then it is totally preventable. For metoclopramide, because of its issues with the extrapyramidal effects, so it is considered as a second line drug and should be used only for the short term. Right, so guideline recommends that you should use only for the short-term use. Maximum dose of 30 milligram in 24 hours should be used, or 0.5 milligram per kg body weight in 24 hours, whichever is lowest. Maximum duration you can use is for 5 days. If you are using intravenously, then it should be a slow bolus injection and should be given over a period of 3 minutes to help minimize the risks. What about rehydration? So we already talked in those charts. Normal saline is the best one with additional potassium chloride in each bag. With administration guided by daily monitoring of electrolytes is the most appropriate intravenous hydration. What other things you may have in your exam questions? What other options? They are very fond of not giving normal saline and looking for what you want to answer. So Hartmann solution is the another good answer, right? You may have that in the options. So Hartmann's, Ringer's, and normal saline, they could be the good options which could be available. Dextrose containing solutions may precipitate Wernicke encephalopathy in thiamine deficient states. So high doses of parenteral thiamine should be given to prevent Wernicke encephalopathy. What is specific in the antenatal care in these patients? So women are advised to continue with their yes. Yeah.
Ma'am, what about giving ringer lactate in hyperemesis?
See, normally the first choice is normal saline. Second good answer for the exam is Hartmann's. And if both are not in option, then choose Ringer.
Okay, ma'am.
This is the sequence of your answer. I am fixing how you have to answer in the exam. So first choice, look for normal saline with KCl. That is the first choice. Not available, choose Hartmann's. Not available, choose Ringer's. Right? Fine?
Okay, ma'am. Okay, ma'am.
So antenatal care of women with NVP, women are advised to continue with their antiemetics where appropriate. So when the patient is discharged, she can keep on taking antiemetics at home. Women with severe NVP or hyperemesis, where the weight gain in pregnancy is less than 7 kg, right? They have an issue of fetal growth restriction or low birth weight babies or preterm birth. So these patients require serial monitoring, fetal growth monitoring scans. So they are the patients who are severely affected. And how will you see it as a severely affected? When the weight gain in the pregnancy is less than 7 kg throughout pregnancy. Depending on the quality of life which is affected, patient may need psychological support, social support that should be organized. And in severe cases, you should involve multidisciplinary team. So what are the factors to be involved in multidisciplinary team? One
Excuse me,
is you
ma'am.
may require
Excuse me,
guest.
ma'am. I have a question. This weight gain is 7 kg. This is for both primary and multi both.
Yes, they haven't defined it for two different categories. They are just mentioned as one figure only in the guideline.
Okay, thank you.
Yeah. So psychological and the social support is required. So what is included in MDT? MDT, one is you will require advice of dietitians, so diet specialists. Then you require the psychological support, so mental health counselors you require. And then you may require the help of endocrinologists. So they all constitute the MDT, right? So whatever help you require in managing, or if patient has any comorbidities like diabetes or epilepsy, you may require these further help too. So these all will constitute the MDT. But the diet and the counselors, they are the two basic things which are usually required for all the patients who are severely affected. Role of enteral feeding and total parenteral nutrition. So parenteral nutrition should only be considered as a multidisciplinary approach when all other treatments have failed to sufficiently control symptoms, as it is inconvenient, expensive, and can be associated with serious complications such as thrombosis, metabolic disturbances, and infection. Enteral tube feeding options to consider include nasogastric tubes, nasoduodenal, or even the nasojejunal, which can be inserted under the radiological guidance. Or percutaneous endoscopic gastrostomy or gastrojejunectomy feeding can be considered. Problem with the enteral tubes are there that feeding is very good, but then it is difficult for the patient to tolerate. Problems with the subcutaneous is that that may form the abscess, infection can be there, or later on can be fistula formation. So they also have their own issues. Therefore, you require a multidisciplinary approach to assess that patient really needs that, because they are not very good things. Parenteral feeding with the peripherally inserted central catheter is often better tolerated than the enteral feeding, but it again carries the risk of infections and the vascular complications like thrombosis. What are the indications for termination of pregnancy? So 10% of women with hyperemesis will terminate a wanted pregnancy due to this condition. Most commonest cause of terminating is lack of self-care. She could not take care of herself. Second commonest is that she feels that with so many drugs or with so many issues, her baby may not be normal. Treatment options of antiemetics, corticosteroids, enteral tube, parenteral feeding, and correction of electrolyte or metabolic disturbances should be considered before deciding that only option is TOP, right? Again, this is something which patient is opting in last. So again, a multidisciplinary approach is very, very important, right? Because she wanted that pregnancy, but you are terminating it. So MDT approach is very important, and proper psychological support, proper counseling is very, very important, and proper documentation is important. These points I am highlighting because they are points of patient safety, right? So these are important points to be considered. Long-term effects. What are the long-term effects? So usually there are no such any increase in mortality or morbidity in the long term. Only the patients who are severely affected they may have increased risk of depression, anxiety, and even in post-traumatic stress disorders in postpartum period. Risk of recurrence in future pregnancies is high, 15 to 81%. This is for any type of NVP or hyperemesis, which requires treatment. Symptoms should resolve rapidly after the birth. Where symptoms do not resolve, further investigation should occur with the referral to endocrinology and gastroenterology. So if after pregnancy also symptoms do not resolve, then you have to go for the endocrinology and gastroenterology. Case reports have shown that sometimes hyperparathyroidism has this type of presentation, and that is detected later on. So therefore, that has to be taken care of. I think I missed one point in the previous slides when we were talking of serial growth scans. It is basically, I told you, the weight gain is not proper when we require these things. Secondly, when your hyperemesis continues into second and third trimester, right? Usually we said it by 20 weeks patient is better. But if it continues into second and third trimester, then also you require the serial growth scans, right? So that is there. Now, these types of patients who are continuously having this problem, they may continue that having it after the birth also. So in that case, you may require further referrals to rule out other causes. Because if it is persisting beyond pregnancy, then most likely it had some other cause which was not diagnosed at that time. Now, looking at the kids, so small increase in anxiety disorder testicular cancer seems very weird, but yes, it is mentioned in talk. Small in guidelines, sorry. So small increase with testicular cancer, aged up to 40 years, attention deficit hyperactivity disorder, and autism in children of mothers with the hyperemesis can be seen. But of course, not very good evidence is there. There are small studies with lot of inhomogeneities. But yes, one point mentioned in the exam, so in GTG, so maybe an important exam point. What is advice for the future pregnancies? Self-reported recurrence of hyperemesis is high. So if it was hyperemesis in the previous pregnancy, so she is so much afraid that even with some amount of symptoms, she is very much cautious. So self-reported recurrence is very, very high. So what all you have to do, you have to start the lifestyle or the dietary modifications early in this next pregnancy. And she may also like to use the antiemetics from the early part of the pregnancy. So that will actually decrease her chances of getting admitted in the hospital. So this is advice for the future pregnancies. So this was all about the guideline of nausea vomiting. And the important features which are different is, one is ketone, that is very important thing. Definition of hyperemesis is now different, it is more subjective. Metoclopramide subcutaneous, community management with IV fluid at home, hospital, in-house hospital, that concept is new. And then adding the various drugs and trying to manage in the community, that is also a bit of new change. And the management or with the PUQE inpatient and all those, that is slightly changed, largely what we used to do previously as well. So these are the few changes which are going to make a difference in your exam questions. So that was all about this guideline. Your questions are welcome.
Excuse me, ma'am. Ma'am,
Okay,
out of
yes.
this puke score and HELP score, we are considering the puke score even now. So,
Yes.
what is the relevance and where is the help or the new score going to be used in the
So
questions?
they haven't used that exactly in the this actually the tables they have given, they are particularly for the GP and the community people who are managing, right? So they are
Okay.
given them according to the puke score, but HELP is also another scoring system which can be used. So mild, moderate, and severe is also classified according to that. But PUQE still remains to be the more commonly used system.
Okay, ma'am. Okay, thank you. Thank you.
Okay, great. Thank you, Dr. Zarina. Thank you, Dr. Hassan. So any more questions from anybody? Okay, great. Thank you. Thank you for joining in. Thank you, Dr. Harshita. Thank you, Chavi, Dr. Chavi. Thank you, Dr. Anu. Thank you, Dr. Nidhi. Okay. Thank you. Thank you, everyone, for joining, and hope you enjoyed the session. And that's all for this guideline. Good night. Take care. Bye-bye. Yes, it is enough. Yes, Dr. Surya, yes, it is enough to remember like what is mild, moderate, and common, so that you can answer your questions accordingly. That is the most important thing. Yes. Yes, recording will be published on your portal. So yes, you will get, and even the new students who have joined, they will get the it on YouTube as well. Yes. Yes. Okay. Bye bye. Good night. Take care.